Imagine a bone so incredibly strong, I mean, so fundamental to every single step you take, every time you stand up, that breaking it usually needs the kind of, well, violent force you see in things like high-speed car crashes, or maybe falls from a significant height.
Hmm,
We are talking about the femur, your thigh bone. It's the largest, strongest bone in the human body, and specifically its shaft, that long tubular bit between your hip and knee.
that's right.
Breaking that isn't just a simple fracture, it's a major traumatic event. Now, while it most often takes massive energy, sometimes, particularly in older adults, maybe with weaker bones from osteoporosis, even a simple fall can be enough.
Yes, that's a key distinction. Low energy versus high energy.
Exactly. So the huge question becomes, how do we actually go about fixing something so fundamentally important, so robust, when it's shattered? And what are the layers of complexity, the hidden pitfalls that professionals absolutely must understand to get it right? Welcome to the deep dive. Our mission here is pretty simple. We take a stack of sources, could be the latest research, clinical articles, expert notes, and we plunge right into them. We pull out the vital nuggets, the surprising facts, the essential knowledge that helps you cut through all the information overload and become truly well-informed, fast. Today, we are undertaking a deep dive into the intricate world of femoral shaft fractures, pulling insights directly from the material you've shared with us. And joining us to guide us through these sources, to help us understand what's really most important, is an expert who's uniquely positioned to synthesize complex medical information. We have with us Professor Mo Imam, who has the perfect background to navigate the nuances of orthopedic trauma. We really couldn't ask for a better guide to help us unpack all of this. Right then, let's jump straight in with a rapid-fire setup just to get a sense of the landscape. Given that these fractures typically result from such high-energy incidents, what's the profile of the person we're usually talking about, and why is this injury such a big deal, not just, locally to the bone, but for the patient overall?
Well, based on the epidemiology and the sources, the classic patient is typically a young individual, often aged between 15 and 40. And as you correctly noted, the cause is almost invariably high-velocity trauma. Think of serious motor vehicle accidents, maybe someone being hit by a car, significant falls from height, or even things like gunshot wounds.
So, major impacts.
Precisely. And it's a significant medical event because the sheer force required means other, potentially life-threatening injuries are very common. They must be anticipated. Also, there's considerable potential for internal blood loss into the thigh, which can be quite substantial. Although it's worth noting, an isolated, closed femoral fracture on its own is less likely to cause profound hypotension compared to, say, a pelvic fracture.
Ah, okay.
But it's a clear signal of a major systemic insult to the body.
That context about associated injuries and the potential blood loss is absolutely crucial. Now, thinking about treatment, how does fixing a fracture in the largest weight-bearing bone in the body fundamentally differ from repairing something smaller, like, I don't know, a bone in the wrist or forearm? And what's considered the mainstream or perhaps the gold standard approach today?
It differs dramatically. The femur has to withstand immense forces, and it's absolutely central to mobility.
Hmm.
Unlike many upper limb fractures, non-surgical treatment like casting or bracing, it's rarely an option for adult femoral shaft fractures.
Right.
The forces at play, the muscle pulls, and the critical need to restore precise lengths, alignment, and rotation for weight-bearing function almost always necessitate surgical intervention. And the widely accepted gold standard technique, supported by significant evidence in the sources, is intramedullary nailing that involves inserting a specifically designed metal rod down the central canal of the bone.
Intramedullary nailing, so fixing it from the inside out, essentially. Fascinating. And finally, before we dive deeper into the specifics, you highlighted that associated injuries are a major factor. What's one significant, perhaps surprising, associated injury that might not be immediately obvious on a standard X-ray, but that surgeons absolutely must be vigilant for?
Well, one crucial injury that is easily overlooked initially is damage to the ligaments around the knee on the same side, the ipsilateral knee. The sources, particularly one study mentioned, report a surprisingly high incidence, up to 20% of significant knee ligament injuries occurring simultaneously with a femoral shaft fracture.
20%, that's quite high.
It is. This includes the anterior cruciate ligament, ACL, posterior cruciate ligament, PCL, medial collateral ligament, MCL, and lateral collateral ligament, LCL, or sometimes even complex multi-ligament injuries. So, meticulous assessment of the knee after the femur has been stabilized is absolutely vital. Missing these can lead to chronic instability, pain, and poor long-term function in the knee.
Wow. 20% concurrent knee ligament injuries. That is far higher than I'd have guessed and really underscores the need for a complete assessment. Okay, that gives us a clear picture of the stakes and the potential hidden issues. Let's really start our deep dive now by understanding the injury itself. What exactly is the femoral shaft? What does it do? And how does breaking it impact things?
Right. So the femoral shaft is essentially that long, relatively straight tube of bone that makes up the vast majority of your thigh. Anatomically, it extends from just below the hip joint, specifically below the lesser trochanter, where certain hip muscles attach, all the way down to the wider flare of the bone just above the knee, where the femoral condyles are located.
And its function.
Its function is absolutely fundamental. It transmits forces from your body weight down towards the ground and absorbs forces coming up from the ground. It's constantly subjected to axial loading, bending forces, and rotational or torsional forces,
Yeah.
particularly during dynamic activities like running or twisting. The bone itself has a natural slight forward or anterior bow, which is actually important for distributing these stresses effectively. And as we've touched upon, the powerful muscles surrounding the femur, the quadriceps, hamstrings, adductors, abductors exert significant forces that can influence how the bone breaks and, importantly, how the fragments displace.
Okay.
So when this core pillar breaks, you lose that structural support instantly, rendering the limb unusable and, of course, extremely painful.
It truly is a central pillar. And you mentioned the demographics earlier, young patients, high energy trauma. Does the way the bone breaks, the pattern of the fracture, tell us something about the forces involved?
Absolutely. The fracture pattern is a direct consequence of the type and magnitude of forces applied. High-energy impacts, like those from severe car crashes, are the predominant cause in younger, healthy individuals. These often lead to more complex breaks, think commended or segmental fractures.
Right. More fragmentation.
Exactly. However, as noted in the sources, lower energy mechanisms, particularly simple falls in the elderly, are also significant causes. These typically result in simpler fracture patterns, primarily because the bone is already weakened by conditions like osteoporosis. A concerning subset, mentioned as about 15%, are open fractures, where the bone fragments actually pierce the skin. This is a critical factor because it immediately introduces contamination and drastically increases the risk of deep infection and associated soft tissue complications, making management much more challenging.
So the force level really dictates the break's complexity, and open fractures add a whole other layer of risk. Okay, when a patient with this kind of injury arrives in the emergency department, what's the absolute top priority? The sources repeatedly mention EMST principles, emergency management of severe trauma.
Yes, EMST or ATLS, Advanced Trauma Life Support, as it's also widely known, is the fundamental framework here. Because, as we keep reinforcing, these patients are often multiply injured. The initial focus is never solely on the fracture itself. It's always on identifying and managing immediate life threats following the systematic ABCDE approach. Airway, breathing, circulation, disability, neurological status, and exposure. A full body exam to find all injuries.
ABCDE first.
Always. Controlling hemorrhage is paramount. While an isolated closed femoral fracture, as I said, is less likely to cause profound shock, the potential for massive blood loss into the thigh cannot be underestimated. Needing blood transfusions is certainly not uncommon. Beyond that system-wide stabilization, the next critical step in the trauma bay is a rigorous secondary survey to identify absolutely all injuries.
And drilling down on that secondary survey, you mentioned some must-not-miss associated injuries earlier. What were those again, and why are they so important not to overlook?
This is perhaps one of the most critical clinical takeaways from the material. You have diligently looked for associated fractures around the hip on the same side, an ipsilateral neck, a femur fracture, perhaps a pelvic fracture, or an acetabular, that's the hip socket fracture. These can be subtle, sometimes obscured by swelling or splints, or easily missed on initial standard x-rays.
So you need to actively look.
Actively look. Careful review of pelvic images, potentially a CT scan, and sometimes even intraoperative fluoroscopy during the femur surgery itself are necessary checks. Then there are those knee ligament injuries we discussed, remember, up to 20% incidence reported. Assessing the knee carefully, usually after the femur is stable, is essential. And don't forget the floating knee scenario. That's fractures of both the ipsilateral femur and tibia, which significantly increases complication rates. Finally, a thorough neurovascular examination of the limb is absolutely non-negotiable. While vascular injury proximal to the knee is relatively rare, around 1% incidence is mentioned, missing it can lead to devastating outcomes, including, potentially, limb loss.
It truly sounds like a full-body trauma assessment is key, not just focusing on the obvious broken thigh bone. before definitive surgery, is there a role for temporary measures to stabilize the leg?
Oh yes, temporary stabilization is standard practice. It serves multiple purposes, alleviating the excruciating pain, reducing further soft tissue injury or bone displacement, and helping to limit ongoing blood loss. Traction splints are very commonly used in the pre-hospital or emergency setting.
Like a Thomas splint.
Exactly, the classic Thomas splint applies countertraction against the pelvis with a strap around the ankle or foot. Pneumatic traction splints are another option, though they seem to have a limited duration of effectiveness, often only holding reduction for maybe around 12 hours or so. Carbon traction splints and skeletal traction, where pins are placed directly into bone, can also be used. Skeletal traction is sometimes employed for longer temporary periods before definitive surgery, especially if immediate surgery is impossible for other reasons, perhaps patient instability.
So these temporary measures are really about damage limitation and comfort while preparing for the main event. Once the patient is stable, how do clinicians actually describe and classify these fractures? Why are these classification systems important?
Classification systems provide a common language, which is vital for communication between healthcare professionals, and they also help guide the treatment strategy. The Winquist classification is one system widely mentioned, focusing on the degree of comminution, how fragmented the bone is, and crucially, the amount of cortical contact remaining between the main bone pieces. It ranges from type 1, which is minimal comminution, it's essentially stable, up to type 4, which is segmentally comminuted with no inherent stability whatsoever. Understanding the Winquist type is crucial because increasing comminution means less stability and a greater reliance on the implant, the nail, for stability. This often dictates the need for lock fixation, using screws at both ends to prevent collapse or shortening.
And the other system, AOOT.
Yes, the AOTA classification is another, more detailed system used globally. It uses alphanumeric codes to classify fractures based on their pattern: simple, like transverse, oblique, spiral, wedge, where there's a third fragment, or complex multifragmentary. It provides a very granular description, which is valuable for research, precise communication, and guiding specific surgical approaches. Both systems essentially help ensure that when one surgeon describes a fracture, another understands its severity and characteristics clearly, like a shared language.
Right, like a standardized shorthand for complexity. And those patterns you mentioned, transverse, oblique, spiral, comminuted, how do those different shapes relate back to the injury mechanism and potential challenges?
Each pattern really gives clues about the forces involved. A transverse fracture runs straight across the bone. This usually results from a direct blow or perhaps a bending force. Oblique fractures are angled breaks, typically caused by bending forces as well, but often associated with higher energy.
Okay.
Spiral fractures, which twist around the bone like the stripes on a barber pole, are caused by significant twisting or torsional forces. Comminuted fractures, where the bone shatters into 3 or more pieces, are the hallmark of very high-energy trauma. And an open fracture, well, regardless of the underlying pattern, signifies severe soft tissue injury and the high contamination risk we discussed. Understanding the pattern isn't just academic. It influences surgical strategy, for example. A simple spiral fracture in otherwise good bone might sometimes be treated slightly differently than a highly comminuted break requiring more robust fixation.
So, the bone tells a story of how it was broken. And how does that story, combined with the physical signs, lead to a diagnosis? What does the diagnostic process typically involve?
Well, the diagnosis is usually quite evident clinically. The symptoms are dramatic: immediate, intense pain in the thigh, often radiating down to the knee, a complete inability to put any weight on the leg, and usually a very obvious deformity. The leg often appears shortened, bowed, or angled abnormally. Significant swelling and bruising develop quickly, too.
Sounds pretty clear.
It usually is locally. Patients might also report numbness or tingling below the fracture site if nerves are affected. But beyond the obvious local signs, it's critical to be alert for systemic symptoms that could indicate complications. Things like extreme swelling, maybe a fever, or confusion, which might point towards developing compartment syndrome, infection, or other systemic issues like fat embolism. The diagnostic process itself starts with a detailed medical history. Understanding the injury mechanism, the speed of impact, whether a seatbelt was worn, how far the patient fell, all this is vital for anticipating other potential injuries. A thorough physical exam follows, checking the obvious deformity, looking carefully for any open wounds, gently palpating for crepitus, that grating sound of bone fragments, assessing pulses and sensation in the foot to check blood flow and nerve function, and systematically examining for all those crucial associated injuries we discuss, from the hip right down to the knee.
And then imaging.
Imaging confirms it. Plain X-rays, typically AP, anterior, posterior, and lateral views of the entire femur, including the hip and knee joints, are the primary tool. They confirm the fracture, its exact location, the pattern, and the degree of displacement. For complex cases or if there's suspicion of other subtle injuries like a concurrent neck fracture, a CT scan can provide invaluable cross-sectional detail. MRI is less common for acute shaft fractures, but can be useful perhaps for stress fractures or subtle incomplete breaks sometimes seen in athletes.
So, combining the patient's story, the physical exam, and the imaging gives the complete picture. Once diagnosed, the question of surgical timing becomes critical. What's the general thinking on when to operate?
For an isolated femoral shaft fracture in an otherwise stable patient, the general consensus based on the sources is to proceed with definitive surgical fixation relatively early, ideally within 24 hours of the injury. Studies mentioned, like one by Harvin et al., have demonstrated that this early fixation, usually with intramedullary nailing, is associated with a reduced incidence of pulmonary complications, things like pneumonia, pulmonary embolism (PE), and acute respiratory distress syndrome (ARDS. It's also linked to decreased hospital lengths of stay.
And the reason for that?
The rationale is that quickly stabilizing the fracture reduces pain, limits ongoing blood loss, and dampens the systemic inflammatory response triggered by the injury and unstable bone fragments. This allows for earlier patient mobilization, which is key to preventing those pulmonary issues.
Okay, early is generally best for isolated injuries, but you mentioned these often occur in polytrauma patients, someone with a broken femur and other major injuries. Does the timing change then? This is where it gets really interesting, isn't it?
Yes, absolutely. This is precisely where the concept of damage control orthopedics, or DCO, becomes paramount. In severely injured polytrauma patients, those with significant head, chest, abdominal, or perhaps pelvic injuries, alongside the femur fracture, the body is in a state of intense systemic inflammation.
Right.
Their inflammatory markers, things like IL-6, are significantly elevated. Performing a major, potentially lengthy procedure like definitive intramedullary nailing during this peak inflammatory phase can essentially act as a second hit to the already stressed system.
A second hit.
Yes, this can overwhelm the body's response and significantly increase the risk of developing serious complications like ARDS and potentially multi-organ failure.
So you avoid the big surgery initially.
Exactly. The DCO strategy addresses this. Instead of immediate definitive fixation, the femur fracture is temporarily stabilized using a less invasive method, typically an external fixator. Pins are placed into the bone above and below the fracture and connected outside the body by bars.
Ah, I see.
This provides sufficient stability to control pain, reduce bleeding, and facilitate patient transfer and initial resuscitation in the ICU, but it's a much less physiologically disruptive procedure compared to definitive nailing. The patient then returns to the intensive care unit to focus on stabilizing all their other critical injuries, optimizing their breathing, circulation, perhaps addressing a brain injury, and so on. Definitive surgery, the intramedullary nailing, is then deliberately delayed until the patient's overall physiological status improves and that inflammatory storm begins to subside, which is often around day 6 to 8 post-injury, sometimes a bit longer.
So you're prioritizing the systemic stability over immediate perfect bone alignment in those cases. Does delaying the definitive bone fixation actually improve outcomes?
The evidence strongly suggests it does, specifically in this high-risk group of polytrauma patients. A seminal study by Pape et al. Back in 2002 compared early total care, meaning early definitive fixation, with DCO in these severely injured patients. They found that the DCO strategy resulted in a statistically significant reduction in the incidence of both multi-organ failure and ARDS. The rates dropped from around 15% in the early fixation group down to 9% in the DCO group.
That's a substantial reduction.
It is. And critically, this reduction in systemic complications was achieved without increasing local complications like infection or non-union of the fracture itself.
Reducing those severe complications by almost half just by changing the timing? That's a really powerful finding.
It is indeed. It really highlights the crucial point that in polytrauma, managing the patient's overall physiological state is paramount. Deciding on surgical timing becomes a complex clinical judgment, balancing the benefits of early fracture stability against the potentially devastating systemic risks in an already compromised patient. It's a cornerstone of modern trauma care, based firmly on evidence.
That really shifts the focus from just fixing the bone to managing the whole injured system. So once the decision is made for definitive fixation, either early for isolated injuries or later following DCO, let's delve into those surgical options. You mentioned intramedullary nailing is the gold standard. Can you break down the key techniques and what the evidence says about them? We've explored the complex decision of surgical timing, especially in polytrauma with damage control orthopedics. Now, let's move into the operating theater and discuss the definitive ways these femoral shaft fractures are fixed. You've established intramedullary nailing, IMN, as the gold standard.
Right.
What does this technique actually involve?
Right. Intramedullary nailing is precisely what it sounds like. Placing a strong metal rod, or nail, directly down the central canal, the medulla of the femur, which is its natural internal cavity. This acts as an internal splint, stabilizing the fracture from the inside. The technique typically involves making a relatively small incision near the hip, or sometimes the knee, inserting the nail through a specific entry point, passing it across the fracture site under X-ray guidance, and then securing it in place with screws at both ends. These are the proximal and distal locking screws to prevent shortening, rotation, and angulation.
Okay, so it's load sharing. The bone itself still takes some stress, but the nail holds everything in alignment. There seems to have been a significant debate in the literature about reamed versus unreamed nailing. What's the difference, and why has this been such a point of contention?
Yes, this has been a key area of research for quite some time. With unreamed nailing, you insert a nail directly into the canal as it is, using a nail that fits the narrowest part, the isthmus. With reamed nailing, you first use progressively larger flexible drill bits, called reamers, to enlarge the intramedullary canal before inserting a consequently larger diameter nail.
And the controversy.
The historical concern with reaming, particularly in polytrauma patients or those with chest injuries, was that the process of reaming could increase the risk of complications like fat embolism. This is where bone marrow contents, including fat globules, are potentially pushed into the bloodstream during the reaming process, and the theory was this could travel to the lungs and contribute to ARDS or other pulmonary issues.
Ah, okay, that was the fear.
That was the fear. However, the evidence has really evolved on this. The Canadian Orthopedic Trauma Society, COTS trial, published in JBJS American back in 2003, was a landmark study. It showed a significantly lower rate of non-union. That's the failure of the bone to heal with larger reamed nails. The rate was only 1.7% compared to 7.5% for the smaller unreamed nails. That's quite a difference.
A huge difference.
And more recent evidence reinforces this. A meta-analysis by Lai et al. In 2016, which pooled data from multiple randomized controlled trials, concluded that reamed nails led to shorter union times and reduced rates of non-union and reoperation. And critically, they found no statistically significant increase in rates of ARDS, mortality, or significant blood loss with reamed nails compared to unreamed. Furthermore, the COTS group specifically looked at ARDS in multiply injured patients receiving either reamed or unreamed nails in a 2006 paper. They found a very low incidence of ARDS overall, and importantly, no significant difference between the two techniques.
So the fear about reaming causing ARDS, particularly in those already vulnerable patients, seems to be largely unfounded by the more recent robust data. And reaming actually significantly improves the healing rates.
That's precisely the conclusion from these key sources. The weight of evidence strongly supports reamed nailing for achieving better, more predictable union outcomes, without substantially increasing the risk of those systemic complications that were once a major concern. This represents a significant shift in understanding and practice compared to perhaps assumptions from 20 or 30 years ago.
That's a really important clarification for anyone in the field. Another technical point mentioned is the entry point for the nail, whether it's inserted from the top of the greater trochanter or the piriformis fossa slightly medial to it. Does that choice impact anything significant?
Yes, this is another area where surgical technique refinement continues. A systematic review by Kumar et al. In 2019 specifically compared the outcomes of trochanteric versus piriformis entry points for antegrade nailing. They found that the trochanteric entry point was associated with reduced operating time and less radiation exposure from thoracoscopy. And importantly, a lower incidence of post-operative abductor muscle weakness. Those are the muscles that lift your leg out to the side, which translated to improved functional outcomes. Union rates themselves were similar between the two entry points.
Reduced OR time, less radiation exposure, and better functional results, like potentially less limping. That sounds like a fairly clear advantage for the trochanteric approach based on that evidence.
It certainly suggests it offers distinct advantages in terms of surgical efficiency and potentially the patient's recovery experience, particularly regarding hip function.
Could you just give us a brief sense of the surgical technique itself? It sounds like it requires significant precision to navigate that nail down the bone correctly.
It certainly does. It's a technically demanding procedure. The patient is typically positioned on a specialized orthopedic traction table. which allows the surgeon to apply longitudinal pull or traction
Mhm.
to the limb to help align the fracture fragments under imaging control. General anesthesia is used.
Mhm.
For antegrade nailing, which is inserted from the hip end, the leg is usually positioned to allow access to the hip area. A relatively small incision is made, and an entry point into the intramedullary canal is created, either at the tip of the greater trochanter or slightly medial in the piriformis fossa, depending on the chosen technique and the specific nail design. Getting this entry point precisely right in both the AP and lateral planes is absolutely crucial to avoid later issues like malalignment or even iatrogenic fracture. Then, a flexible guide wire is inserted down the canal across the fracture site. This is also a key challenging step, visualizing the fracture under fluoroscopy, which is live x-ray, and manipulating the limb to get the bone fragments aligned so the wire can pass across smoothly. This might require various reduction tools, joysticks inserted into bone fragments, or sometimes even a small additional incision directly over the fracture site to help manually line things up.
Right, getting it lined up is critical.
Absolutely. Once the guide wires are crossed and the alignment looks good on both X-ray views, the required nail length is measured using the guide wire. If reaming is planned, the flexible reamers are passed over the wire sequentially, enlarging the canal usually 1 to 1.5 millimeter larger than the intended nail diameter. Then, the intramedullary nail itself is inserted over the guide wire. This needs to be done carefully, often with gentle hammer taps, constantly watching the fracture site under fluoroscopy to ensure it doesn't get distracted, pulled apart, or excessively impacted. One specific challenge, as mentioned in the sources, is managing the typical deformity of the proximal upper fragment caused by muscle pull. The iliopsoas muscle tends to flex it forward, the gluteus medius and minimus abduct it sideways, and the short external rotators rotate it outwards. The surgeon needs to consciously counter these forces during reduction and nailing. Finally, once the nail is fully seated, it's secured with locking screws. Proximal locking, screws near the hip, is often done first, aiming for good purchase in strong bone, like the lesser trochanter or the calcar. Distal locking, screws near the knee, can be more challenging due to the shape of the distal femur. Techniques like the perfect circle technique under fluoroscopy, where you align the C-arm perfectly with the hole in the nail, or using specific aiming devices attached to the insertion handle, are employed to accurately place these screws through the holes in the nail. It's an intricate process requiring constant feedback from imaging to ensure correct alignment, length, rotation, and ultimately stable fixation.
That level of coordination and precision sounds immense. So IMN is the standard, but are plates and screws ever used for femoral shaft fractures, and what are the trade-offs there?
Yes, traditional plating techniques with plates and screws are still used, but typically for specific indications where IMN might not be the ideal solution. These situations might include fractures that extend very close to or actually into the hip or knee joint, where a nail wouldn't provide adequate fixation of the joint fragments. Or perhaps in cases with a concomitant vascular injury nearby, where the surgeon needs better direct access to the blood vessels for repair. Other indications could be when the patient has a pre-existing deformity, or maybe hardware already in the canal from a previous surgery, making nailing difficult or impossible. Plating is also commonly used in skeletally immature children, where you want to avoid crossing the growth plates with the nail. And importantly, plates are sometimes used specifically to treat non-unions, particularly complex ones. However, plating the femoral shaft generally has significant disadvantages compared to IMN. It usually requires a much larger surgical incision and more extensive stripping of the soft tissues and muscles away from the bone surface to expose it for plate application. This can compromise the bone's periosteal blood supply, which is crucial for healing.
Blood supply is key.
Absolutely. Furthermore, the plate is typically placed on the lateral outer side, which is the tension side of the femur. This means the plate itself bears the brunt of the bending forces during weight bearing. If the bone healing is slow or fails, non-union, the plate is subjected to repetitive high stress and is at significant risk of fatiguing and eventually breaking. Studies mentioned, like one by Giesler et al. From 1995, showed reasonable union rates with plating, maybe around 93% at 16 weeks, but often highlighted the need for bone grafting alongside the plate to enhance healing. And plating typically necessitates a period of non-weight bearing or very restricted weight bearing post-surgery, which isn't always necessary with a stable nail construct.
So plates have their place for specific scenarios, but they come with potentially higher risks to bone healing and hardware failure compared to the load-sharing nature of a nail situated inside the bone. Let's pivot back to those complex associated injuries you flagged up earlier, things like floating knees or shaft neck combinations. How do these increase the challenge of treatment?
Associated injuries dramatically escalate the complexity and, frankly, the potential for complications. The floating knee, which remember is an ipsilateral femur and tibia fracture in the same limb, is a prime example. You're dealing with two major long bone fractures requiring stabilization. This scenario is consistently associated with higher rates of complications like non-union or malunion, healing in a poor position, in both bones, significant knee stiffness afterwards, and also heterotopic ossification, that's abnormal bone formation in the soft tissues around the knee.
So a double whammy.
Pretty much. Management often involves fixing both fractures surgically, sometimes using a single incision approach at the knee to insert a retrograde femoral nail, going from the knee upwards, and an antegrade tibial nail, going from the knee downwards. The specific techniques and timing need very careful planning. Then there's the dreaded combination of an ipsilateral femoral shaft fracture and a neck of femur fracture. This occurs in up to 10% of cases, according to the sources, and is notoriously easy to miss on initial assessment, especially if the neck fracture isn't displaced much.
10% is not insignificant.
Not at all. The sources stress this repeatedly. You must actively look for this. Often requires careful scrutiny of good quality pelvic films, potentially a CT scan if there's any doubt, and even using intraoperative fluoroscopy to check the hip during the femur surgery. The critical principle, highlighted in studies like the one by Ostrom et al., is that if there is a displaced neck fracture, you absolutely need to address and stabilize the neck fracture first before fixing the shaft.
Order matter.
Critically, options include fixing the neck with pins or a plate, like a sliding hip screw, and then using a retrograde nail for the shaft, or potentially using a reconstruction nail that's a specialized long nail designed to put screws up into the femoral neck as well as locking screws for the shaft. However, reconstruction nails can sometimes make achieving a perfect anatomical reduction of the neck fracture more difficult and might be associated with a slightly higher incidence of neck non-union. Ostrom's study showed high union rates for both fractures, around 98% for the neck, 91% for the shaft when the neck was fixed first with proximal screws or a sliding hip screw, followed by shaft fixation, typically with a retrograde nail. If, unfortunately, an antegrade shaft nail is inserted before a displaced neck fracture is diagnosed, the nail usually needs to be removed to allow proper reduction and fixation of the neck fracture. It's a situation you really want to avoid.
Fix the hip first. That order of operations sounds absolutely critical to avoid potential disaster at the hip joint, like a vascular necrosis. Are there other complex scenarios worth mentioning briefly?
Yes, definitely. A dislocated hip combined with a shaft fracture is another urgent scenario. The hip dislocation must be reduced immediately within hours to minimize the risk of damage to the femoral head's blood supply before proceeding to fix the femur fracture. This gets even more complicated if there are associated femoral head fractures, known as Pipkin fractures or acetabular fractures involved. Bilateral femur fractures in both thighs are thankfully less common, but represent extreme high-energy trauma. They're associated with a high complication burden and significantly increased mortality rates, reported around 6.9% in one study mentioned. There's also an increased risk of DVT and PE. This is another scenario where damage control orthopedics with initial temporary external fixators is often the preferred strategy to manage the massive systemic impact before attempting definitive fixation, as suggested by Stavros et al. And lastly, segmental bone defects, where a piece of the bone shaft is essentially missing due to the trauma, also present a major reconstructive challenge. These often require multi-stage treatments, sometimes involving temporary stabilization, perhaps placement of antibiotic-loaded cement spacers in the gap, and then delayed bone reconstruction techniques like the masculine-induced membrane technique.
The Mascalet technique, what does that involve, briefly?
It's quite an ingenious two-stage procedure for significant bone loss. In the first stage, after thoroughly cleaning out the wound, debridement, and fixing the fracture gap temporarily, often with an external fixator or maybe a temporary plate or nail, an antibiotic-loaded cement spacer is placed into the bone defect. This spacer does two things. It prevents soft tissue from collapsing into the gap, and critically, it induces the formation of a biological membrane around itself over several weeks, usually 6 to 8 weeks.
A membrane forms around the cement.
Yes, a biologically active membrane. In the second stage, the surgeon reopens the site, removes the cement spacer carefully, preserving this induced membrane, and then packs the bone defect within the membrane with bone graft, often taken from the patient's own pelvis, iliac crest. The membrane appears to contain growth factors and cells that enhance the bone graft's incorporation and promote healing across the gap. Studies looking at critical bone loss in femurs have shown promising union rates using IMN in conjunction with these advanced reconstruction techniques.
That's a fascinating biological approach to essentially engineer a healing environment for significant bone gaps. It's clear these associated injuries and complex scenarios demand sophisticated, often multi-stage management plans. And even with the best surgery, complications can still arise. What are the main complications that surgeons are trying to avoid or manage postoperatively?
Complications are definitely a significant aspect of managing these injuries. They can occur during the surgery itself, things like iatrogenic fractures, meaning a fracture caused by the surgeon perhaps while inserting the nail, or rare but potentially serious injury to nerves or blood vessels near the fracture site. Compartment syndrome is another urgent, potentially limb-threatening complication that requires extreme vigilance in the hours and days after injury or surgery.
Compartment syndrome. That's pressure buildup, right?
Exactly. It's where pressure builds up dangerously within the tightly enclosed muscle compartments of the thigh, usually due to bleeding and swelling. This pressure can compromise blood flow to the muscles and nerves within the compartment. It's a surgical emergency requiring immediate surgical incisions, called fasciotomies, to release the pressure. Delayed diagnosis and treatment can lead to permanent nerve damage, muscle death requiring extensive removal, or even amputation in severe cases. Postoperatively, infection is a major concern, particularly with open fractures where the bone is exposed to the outside environment. Deep infection can be very difficult to treat, often requiring multiple trips back to the operating theater for debridement, cleaning out infected tissue, and prolonged courses of targeted antibiotics. Malalignment, the bone healing crooked, either angulated or rotated incorrectly or non-union, the failure of the bone to heal altogether are also critical issues that often require further surgery. Blood clots, both deep vein thrombosis, DVT, in leg veins, and pulmonary embolism, PE, if a clot travels to the lungs, are significant risks, especially in major trauma patients confined to bed initially. Hence the routine use of preventative measures like blood thinners.
Fat embolism syndrome, while perhaps less common with modern reamed nailing techniques than once feared, remains a potential risk, particularly in patients with multiple fractures or severe trauma. Hardware irritation from the nail or screws causing ongoing pain or bursitis can sometimes occur later on, occasionally requiring hardware removal after the fracture is solidly healed. And as we discussed, those associated knee ligament injuries, if missed initially, can become apparent or symptomatic later on, causing instability or pain. In the longer term, patients can face ongoing issues like persistent non-union, malunion with functional consequences, refracture, though the risk isn't thought to be significantly increased if the nail is removed more than a year after solid union, persistent leg length discrepancy, osteonecrosis, bone death, particularly if the blood supply was severely compromised, and post-traumatic arthritis, especially if the fracture extended into a joint or healed with significant deformity. Malrotation sounds particularly challenging to get right during surgery. How common is that, and how is it diagnosed and corrected if it happens?
Malrotation, where the leg heals with the foot pointing inwards, internal rotation, or outwards, external rotation, compared to the uninjured side, is surprisingly prevalent, though its true incidence is difficult to pin down precisely. Estimates in the literature vary widely, with some studies suggesting rates of detectable malrotation of over 10 degrees might be as high as 30 or 40%.
That high.
Potentially, yes, when measured accurately, often with CT scans. Clinically significant malrotation, the amount that actually causes functional problems, is probably less common, often considered anything over about 15 or 20 degrees compared to the other leg. But when it occurs, it can cause significant functional problems like an abnormal gait, anterior knee pain, or even hip pain, particularly with more severe rotational deformities, say over 30 degrees. Diagnosing it clinically postoperatively can be tricky. Assessing the foot progression angle during walking or comparing the range of hip rotation when the patient is lying flat can give clues, but it's not always accurate. The gold standard for accurate diagnosis and quantification is typically a specialized CT scan protocol that measures the rotational angle between the femoral neck up at the hip and the femoral condyles down at the knee, and compares this to the uninjured contralateral side.
And prevention. How do surgeons try to avoid it?
Prevention is absolutely key during the surgery itself. Techniques described include meticulously ensuring that the cortices, the outer layers of the bone, are perfectly matched and aligned at the fracture site before locking the nail distally. Another common technique is ensuring both patellas, kneecaps, point straight forward towards the ceiling when the patient's hips are positioned neutrally on the operating table. Sometimes comparing the profile or shape of the lesser trochanter under fluoroscopy to the uninjured side can also help judge rotation. It requires constant vigilance during the reduction and nailing process.
And if it does happen?
If significant malrotation is detected soon after surgery, perhaps within the first few weeks before the bone starts to heal solidly, it can sometimes be corrected relatively simply. This might involve taking the patient back to theater, removing the distal locking screws, carefully re-rotating the limb into the correct alignment under fluoroscopic or CT guidance, and then reinserting the distal screws in the corrected position. However, if malrotation is diagnosed later, after the bone has already healed in the wrong position, correction requires a formal osteotomy. This means surgically cutting the bone again, either at the level of the old fracture site or sometimes elsewhere along the femur, rotating it into the correct alignment and then refixing it, usually with a nail or a plate. That's obviously a much more involved procedure with its own risks.
It's quite sobering that getting the twists wrong during the initial surgery could potentially lead to needing to essentially break the bone again later on. And non-union, when the bone just doesn't heal, despite all these techniques, how is that managed?
Non-union is typically defined as the fracture not showing clear radiological signs of healing. For example, bridging callus across at least 3 out of 4 cortices on AP and lateral x-rays by around 6 months after surgery, or perhaps showing no progressive signs of healing on serial x-rays over 3 consecutive months. As we saw with the COTS trial data, it's relatively uncommon with correctly performed reamed nailing, maybe in the region of 1–2%. But the risk is notably higher with unreamed nails or in complex fracture patterns, open fractures, or patients with risk factors like smoking or infection. Management really depends on the specific cause. Is it infection, poor blood supply, excessive motion to the fracture site, not enough motion, a significant gap? And the characteristics of the non-union itself. Is it hypertrophic with lots of non-bridging callus or atrophic with little biological reaction?
So different approaches for different non-unions.
Exactly. Options range from relatively simpler interventions like dynamization. This usually involves removing the distal or sometimes proximal static locking screws from the nail, converting it to a dynamic mode. The idea is to allow controlled axial micromotion or compression at the fracture site during weight bearing, which can sometimes stimulate healing in cases of delayed union, particularly if there's a small gap. Studies mentioned suggest dynamization might be most effective if done relatively early, perhaps between 10 and 24 weeks post-injury, rather than much later for an established non-union. However, for established non-union, dynamization alone is often insufficient. A systematic review mentioned by Vaughn et al. Found that dynamization achieved union in about 66% of cases overall, whereas exchange nailing was successful in about 85%. Their conclusion was that dynamization might be reasonable for delayed union, slow healing, but exchange nailing is generally preferred for established non-union.
Exchange nailing, what does that involve?
Exchange nailing involves removing the original intramedullary nail, then reaming the intramedullary canal again, often to a larger diameter than before. This does two things. It removes any fibrous tissue membrane that might be blocking healing at the non-union site, and importantly, it provides a fresh biological stimulus by exposing bleeding bone surfaces. Then a new, larger diameter nail is inserted, usually with static locking screws at both ends initially. Some sources suggest considering early dynamization of the new nail if healing still seems slow after exchange. Studies like one by Swanson et al. Reported very high success rates, even 100% union in their series of 50 cases treated with exchange nailing. For more complex non-unions, particularly those with a significant bone gap, deformity, or perhaps poor bone quality, additional techniques are often needed alongside or instead of exchange nailing. This might involve removing the implant altogether, surgically opening the non-union site, cleaning it out thoroughly, debridement, correcting any deformity, packing the site with bone graft, often taken for the patient's iliac crest, and then restabilizing, perhaps with a robust plate and screws. Or an increasingly favored approach for challenging non-unions, especially where the existing nail is well positioned and stable, but healing has stalled, is to keep the intramedullary nail in place and augment it. This involves adding a plate, usually a locking plate, along the side of the bone bridging the non-union site, combined with bone grafting placed directly at the non-union site.
Augmenting the nail with a plate and bone graft. That sounds like bringing out the big guns. That systematic review by Medlock et al., that you mentioned cited a remarkable 99.8% union rate with this augmentative plating technique, compared to around 74% with exchange nailing alone in their analysis. That's a huge difference and a powerful example of how treatment strategies evolve based on evidence for these difficult problems.
It certainly demonstrates the effectiveness of combining biological stimulation grafting with enhanced mechanical stability, nail plus plate, to tackle these challenging recalcitrant non-unions. It's become a very reliable option.
And if the non-union is also infected, which just sounds like a complete nightmare scenario.
Infected non-union is arguably one of the most challenging complications in all of orthopedic trauma. Management is complex, multifaceted, and often prolonged, requiring a dedicated multidisciplinary team approach. It typically involves aggressive surgical debridement to remove all infected and non-viable bone and soft tissue. Sometimes antibiotic-loaded cement beads or spacers are placed temporarily in the wound cavity after debridement to deliver high local concentrations of antibiotics. The existing infected hardware, the nail, is usually removed. The canal might be reamed again and thoroughly irrigated. Sometimes a temporary antibiotic-coated nail or an antibiotic cement spacer rod might be placed in the canal. This is always followed by prolonged courses of intravenous antibiotics, guided by culture results from the debrided tissue, often for 6 weeks or more. Definitive fixation, often with a new nail or sometimes an external fixator, along with bone grafting to bridge the defect, is typically delayed until the infection is clearly controlled, based on clinical signs and inflammatory markers. A study mentioned by Pinhan et al., looking at 21 cases of infected femoral non-union, showed that infection was eliminated in 100% of cases treated with this kind of staged approach, and union was eventually achieved in 16 out of the 21 patients directly with this protocol, though some others needed further subsequent surgeries.
That's a real testament to persistent surgical and medical management in the face of incredibly significant complications. Given all these potential issues, what's the overall prognosis and the expected recovery process after a standard femoral shaft fracture?
Well, the prognosis for bone union itself is generally very good with appropriate surgical treatment, particularly with reamed IMN, as the union rates cited are consistently high, often well over 95%. However, the overall recovery and the final functional outcome can vary quite significantly depending on factors like the patient's age and baseline health, the severity and type of the fracture itself, simple versus complex, open versus closed, the presence of those important associated injuries we discussed, whether any complications like infection or malunion occurred, and crucially, patient adherence to the rehabilitation program.
So healing isn't the end of the story.
Not at all. Recovery is definitely a marathon, not a sprint. Typically, bone healing sufficient for reliable, full weight bearing takes around 4 to 6 months. But complete recovery of muscle strength, range of motion, and overall function can easily take a year or even longer, especially for more severe open or highly comminuted fractures, or for patients who smoke, which is known to impair healing. The type of surgery does impact the recovery trajectory. As mentioned, intramedullary nailing generally allows for earlier protected weight bearing and mobility compared to traditional plating, which usually contributes to a better overall recovery and fewer complications related to stiffness or muscle wasting, according to sources like the femur fracture or OFS document.
So even with those high union rates, functional recovery isn't guaranteed to be perfect. Back to 100%.
Exactly. While the bone healing itself is often successful, some patients unfortunately do experience fair or even poor long-term functional outcomes. This might be due to persistent muscle weakness, particularly the hip abductors and knee extensors, which are often affected by the injury or surgery, stiffness around the hip or knee joint, ongoing pain, perhaps from nerve damage or irritating hardware, refracture later on, though the risk isn't thought to be significantly increased if the nail is removed more than a year after solid union, or the development of post-traumatic osteoarthritis, particularly if the fracture involved or was close to a joint or if it healed with significant malalignment. Adherence to a structured progressive rehabilitation program is absolutely critical for optimizing long-term function and mitigating these potential residual issues as much as possible.
That brings us perfectly to rehabilitation. What's involved there, and is early weight bearing generally encouraged with a nailed femur?
Rehabilitation is absolutely fundamental to getting back function. It's not just about the bone healing, it's about restoring the whole limb. It involves a personalized physical therapy program, usually starting soon after surgery, designed to restore muscle strength around the hip and knee, improve range of motion in both joints, regain flexibility, and work progressively on balance, coordination, and eventually gait retraining. It progresses as the bone heals and the patient's pain allows.
And pain management during rehab.
Yes, pain management is also crucial throughout this process to allow effective participation in therapy. It often uses a multimodal approach, combining different types of medications, perhaps simple analgesics like acetaminophen and NSAIDs, though some sources advise caution with NSAIDs in the early fracture healing phase. Maybe gabapentinoids if there's nerve-related pain, muscle relaxants if needed, and sometimes short-term, very carefully managed opioid use for severe pain, with a clear focus on minimizing duration and dose and stopping opioids as soon as the acute pain improves, given the obvious risks of dependency. Regarding weight bearing, with a stable intramedullary nail fixation, early motion and progressive weight bearing are generally encouraged. Often it's weight bearing as tolerated relatively early on, although the specific protocol can vary depending on the fracture pattern, especially comminution, the perceived quality of the fixation achieved at surgery, and the individual surgeon's preference and experience.
So it's not always non-weight bearing for weeks.
No, not usually with stable nailing. The stable IMN provides significant mechanical support, allowing the bone to be loaded relatively early. Some surgeons allow full weight bearing as tolerated almost immediately or within the first couple of weeks. There was that study by Arasiola mentioned back in 2001, which reported 100% union in comminuted femoral fractures treated with reamed IMN, where patients were actually allowed full weight bearing within the first 2 weeks post-op. 400% union in comminuted fractures with weight bearing starting within 2 weeks. That's a really striking finding and speaks volumes about the power of stable internal fixation combined with early functional loading.
It really does highlight how achieving good mechanical stability with the nail allows the biological healing process to respond positively to controlled physiological stress, rather than needing prolonged immobilization. Patients typically start with walking aids like crutches or a walker and progress the amount of weight they put through the leg under the guidance of their physical therapist and surgeon. Finally, looking beyond individual treatment now to prevention, what strategies are highlighted in the sources to try and reduce the incidence of these often devastating fractures in the first place?
Prevention really needs a multi-pronged approach, addressing both high-energy and low-energy causes. Given that high-energy trauma is the main cause in younger people, public health and safety initiatives are paramount. This includes things like improved traffic safety regulations, better road design, promoting seatbelt use consistently, measures to discourage speeding and distracted or impaired driving, and ongoing public awareness campaigns about road safety. Workplace safety measures are also relevant for falls from height.
Okay, that covers the high energy side. What about the elderly?
For the elderly, where low-energy falls often related to osteoporosis are a significant factor, prevention focuses heavily on identifying and mitigating fall risks. This includes multifactorial fall prevention programs that often incorporate exercises to improve balance, strength, and coordination. It also involves home safety assessments and modifications to remove hazards like loose rugs or poor lighting. Addressing underlying medical conditions that might affect balance or cause dizziness is important too. And of course, focusing on bone health through adequate nutrition, ensuring sufficient calcium and vitamin D intake, screening for and treating osteoporosis, and addressing malnutrition, which is linked to increased fracture risk and poor outcomes after fracture in older adults. Post-injury rehabilitation itself can also be seen as a form of secondary prevention, as successfully restoring strength, balance, and confidence in mobility after one fracture helps reduce the risk of future falls and subsequent fractures.
So it really spans from broad societal safety measures right down to targeted individual health and home environment interventions across the entire age spectrum. We have truly taken a deep dive today, haven't we? Covered everything from the basic anatomy and the immense forces involved in femoral shaft fractures, through critical steps in emergency management, focusing on life threats and those crucial associated injuries, understanding the classification systems like Winquist and AOTA, navigating complex surgical decisions like damage control orthopedics versus early total care, delving into the nuances of intramedullary nailing techniques, reamed versus unreamed, entry points discussing those challenging scenarios with associated injuries like floating knees or neck fractures, exploring the wide range of potential complications from infection to malrotation and non-union and how they are managed, and finally landing on the absolutely critical role of rehabilitation and broader prevention strategies. Let's wrap up now with a quick lightning round if you're ready. What's one key framework or concept we discussed today that trauma professionals should always keep front and center when dealing with these injuries?
I'd have to say damage control orthopedics. Recognizing when not to do the definitive surgery immediately in a severely injured polytrauma patient is a critical, potentially life-saving decision. Prioritize a patient's physiology.
Excellent point. And thinking of patients and perhaps their caregivers going through this long recovery, what's one single piece of advice you'd offer them?
Absolute commitment to the prescribed weight-bearing status and, just as importantly, the rehabilitation plan. Your active participation is probably the biggest factor in your long-term functional recovery. Stick with it.
Solid advice. Is there one particular tool or surgical technique from the sources that stands out to you as having significantly improved patient outcomes for these fractures over the years?
It has to be reamed intramedullary nailing. The evidence strongly supports its ability to achieve predictable high rates of union while appropriately managing the systemic risks, allowing for that crucial early mobilization. It revolutionized treatment.
And going right back to the initial emergency assessment in the A&E department, what's a simple but critical step that can make a huge difference down the line?
A thorough, systematic physical examination and a vigilant search for those ipsilateral associated injuries, particularly around the knee and the hip. Don't let the very obvious traumatic femur fracture distract you from finding other important injuries that need managing.
Crucial points, distilled down perfectly. Thank you. Okay, to quickly recap just some of the most important insights from our deep dive today. Firstly, really understand the immense force typically required to break the femur shaft and the inherent severity of this injury. This demands a rigorous, systematic trauma approach right from the outset, guided by principles like EMST or ATLS. Secondly, never underestimate or misassociated injuries. Hip fractures, pelvic fractures, and especially those surprisingly common knee ligament injuries can occur concurrently with femur shaft fractures and require active assessment and management. Thirdly, while temporary stabilization and damage control principles are vital in polytrauma, definitive surgical fixation, predominantly with intramedullary nailing, is the standard for restoring function. And the evidence now strongly supports ream nailing for better, more reliable union rates without the significant increase in systemic risk that was once feared. Fourthly, managing these injuries, particularly in complex cases or polytrauma, involves sophisticated clinical decision-making, carefully balancing the need for early fracture stability with the patient's overall physiological state and inflammatory response. And finally, despite generally high rates of bone healing with modern techniques, potential complications like infection, malrotation, and non-union are serious possibilities that require expert management. Ultimately, successful long-term functional recovery hinges not just on the surgery, but equally on meticulous patient-adherent rehabilitation. If you found this deep dive valuable, please take just a moment to rate and share it so others can benefit too. Professor Imam, thank you so much for guiding us through all that source material and sharing your expertise on what is clearly a very complex topic. It's been incredibly insightful.
My pleasure entirely. It's certainly a challenging injury pattern, and understanding these kinds of nuances discussed today is absolutely vital for good patient care.
As we've heard today, the techniques and the evidence base for fixing a broken femur shaft are highly advanced, leading to, generally, excellent rates of the bone itself healing. But considering the potential for those lingering issues, maybe weakness, stiffness, subtle malrotation, or perhaps misdissociated ligament injuries that can significantly impact long-term function and quality of life. Well, perhaps the real frontier for professionals in this field isn't just perfecting the initial surgical technique, as crucial as that is. Maybe it's about truly mastering the entire patient journey. That means from the initial trauma bay assessment and complex decision-making in the acutely injured patient, through precise surgery and proactive complication management, all the way to truly optimizing patient engagement and achieving the best possible outcomes in comprehensive long-term rehabilitation. It's really about restoring not just a healed bone, but a fully functioning person, something perhaps to consider as you reflect on today's deep dive. That's it for this deep dive. Join us next time as we unpack another essential topic.